I'm Susan Kuyuvin from the Providence Boston CFAR.
I'm Maureen Gundow from the NIH Office of AIDS Research.
So we're moderating the panel on From Recommendation to Reality in our quest to sustain HIV treatment for all. Our first speaker is Dr. Bisola Ojikuto, who is an assistant professor of medicine at the Harvard Medical School, an associate physician within the Division of Global Health, Equity at Brigham and Women's Hospital, and she also holds a joint appointment within the Infectious Disease Division at MGH. Her primary area of research explores the impact of structural factors and social determinants of health. The title of her presentation has just been changed. She just informed us. So it will be Mass Incarceration and Economic Inequality, Impact of the Criminal Justice System on HIV Prevalence Within Neighborhoods in the U.S.
Okay, good morning, everyone, and thank you for inviting me to speak today. I did just change the title of my presentation, but this is something I've been working on for a while. Hopefully, it will generate some interest and discussion. And if you look at your agenda, I am going to say a bit about the National Survey on HIV in the Black community towards the end of this presentation, so you're not going to miss out on that. So in regards to incarceration, unfortunately, the U.S. Is the home to the largest imprisoned population in the world. In 2014, there were more than 2.2 million individuals in the U.S. who were incarcerated, and that includes in state and federal correctional facilities, including prisons and jails. The epidemic of mass incarceration disproportionately impacts the Black community in the U.S., and if you look across the U.S., about 40% of men in prisons are Black. And the reason for this is complicated. Part of it's due to the war on drugs back in the 70s and differential sentencing for crack versus powder cocaine. In 2010, the HIV prevalence amongst the incarcerated population was 4 to 5 times greater than amongst non-incarcerated populations. And this is largely due to engagement in high-risk activity prior to being incarcerated, not while incarcerated. So it's quite interesting. There's a lot of cycling in and out of correctional facilities, particularly in jails, because people only stay in jail for a little over a month or so. People stay in prisons for a longer period of time, but there's also quite a bit of cycling in and out because recidivism rates are high, particularly with drug-related offenses. And there's also criminal justice reform, where nonviolent offenders are being released early to decrease the spiraling cost of incarceration in this country. So what does any of this have to do with HIV on the neighborhood level? Well, there are a lot of structural factors, and by structural, I mean characteristics of the environment that limit or control behavior that you don't really have control over. The two that are most commonly associated with neighborhood level HIV prevalence or country level HIV prevalence are poverty and economic inequality. And it's sort of complicated as to why those are related, and there isn't a causal relationship, and there are lots of mediators that are involved there. But it's certainly important factors to be concerned with. The other factor that's often spoken about is mass incarceration. But the question is, well, what does that really mean, and why does mass incarceration have anything to do with community-level HIV prevalence or onward HIV transmission risk? And there are people who have speculated that it has something to do with male-female ratios, and you're taking men from communities, so you have a higher risk of multiple concurrent partnerships, particularly amongst women. But few people have looked at this issue of prison release, like what actually happens to folks who are going in and out of prisons, what risk factors are they involved in, and what happens in terms of onward HIV transmission when they go back to home. So we need more information about the impact of population level variables like mass incarceration, but also about poverty and economic inequality, both their impact on the individual, and we have some of that data on the national survey that I'll mention later on, and then on the community. So keeping this in mind, the specific aims of this study were to determine the neighborhood level association of prison release, which is the rate of individuals released from prison to communities, with HIV prevalence within urban cities in the US, and to explore the role of neighborhood level economic factors, those that we know a little bit more about, poverty and inequality with prison release on HIV prevalence. So what was our study hypothesis? What was this all about, and why were we thinking that this is important? So our study hypothesis was that mass incarceration increases neighborhood level HIV prevalence. What may happen when a person is in prison is that they may not be offered HIV testing, but they're high risk, or they're living with HIV and don't know it. And we know from data, primarily from the Brown group, who do a lot of work with incarcerated populations, that only about like 20% of correctional facilities actually offer opt-out testing. So that's a missed opportunity. There are also numerous delays in offering antiretroviral therapy to newly incarcerated individuals, even if they were on ART prior to being incarcerated. And then for individuals who choose to engage in high-risk activities while they're incarcerated, or who are forced to engage in high-risk activities while incarcerated, there really aren't a lot of HIV prevention strategies available to them. Condoms are not usually available, lube, there's not PrEP in any of the correctional facilities studied, and also harm reduction in terms of clean needles isn't widely available. But then on prison release, there's also a number of issues. We know that there are problems linking patients who are living with HIV to care and treatment in their home facilities, their home communities, excuse me. And from data, again, from the Brown Group, we know that probably only 20% of prisons and jails actually have comprehensive discharge planning. So actually linking patients to care and treatment in places where they're going to live. And then from a sociologic perspective, we know that in this country, when a person has a history of incarceration, they have a decrease in economic opportunities, which may promote engagement in high-risk activities like transactional sex and drug use. So this was a geospatial study. So our unit of analysis was the zip code. Okay, that's how we defined our neighborhood. Or for the census variables, it was the zip code tabulation area, which is simply a geographic unit that's defined by the Census Bureau to approximate the zip code so that variables can be looked at in that geographic region. Our outcomes were overall male and female HIV case rate per 100,000 in 2012 from 12 cities. And this case rate and the zip code data was taken from their home address or their residential address at diagnosis. And the 12 cities were actually selected based on the availability of data. And this, the data source here was AIDSview.org. In terms of independent variables, our main one was prison release rate, which is the number of adults released from prison per 100 or 1,000 adult population, and that was derived from the Justice Mapping Center. We used 2008 data. In terms of the census variables, we looked at percent living in poverty, economic inequality measured by the Gini coefficient, percent with high school education, and percent race and ethnicity, white, Latino, and black. This data came from American Community Survey data, the 5-year estimates. And then lastly, for those of you unfamiliar with geospatial data, we added a proxy spatial data, a spatial variable, which basically measured the population center of each zip code to the city center. And the idea here was to control for clustering. We know that HIV doesn't occur randomly in space. It's not a random variable, so we wanted to control for clustering. And that was measured in ArcGIS. So we calculated descriptive statistics. We mapped our variables for visual analysis. We calculated Spearman correlations and constructed our regression models. And all of this was done in R except for ArcGIS, which was used to calculate the proxy spatial variable. So if you look at mean HIV prevalence across the 12 cities that we included in this study, there were 1,002 zip codes. Mean overall HIV prevalence was 0.88, male HIV prevalence 1.35, and female HIV prevalence 0.51. We can compare that to data from NHANES across the United States. You see that the data that we have from the 12 cities that we selected, we have significantly higher HIV prevalence in the cities that are included in this study. And if you look across the 12 jurisdictions, you see that the highest HIV prevalence overall, male and female, were found in New Orleans and New York City. So to get a better sense of our independent variables, we looked at our means, standard deviations, and our min-max to look at range. And just to show you, for prison release rate, our mean was 4.4. Our range was quite high, 0 to 208, and that's actually from New Orleans, where there's a very high prison release rate, as well as a high incarceration rate. So as I mentioned, we calculated Spearman correlations between the independent and our dependent variables, and the variables that we ended up including in our model were prison release rate, the Gini coefficient, percent living in poverty, percent black population, and our proxy spatial variable, the distance from city center. So we did not include percent high school education. And the reason why we didn't was largely because it was collinear with poverty. And we also didn't include white or Latino population. Both were inversely correlated with overall and male and female HIV prevalence, though for the Latino population, that correlation was not statistically significant. So I just want to show you our regression models. These are our initial models. We have some more work to do, but let me just go through them so you understand what we saw. So for the issue of economic inequality, 1 unit increase in Gini coefficient resulted in a 15% increase in overall HIV prevalence, a 30% increase in male HIV prevalence, and a 9% increase in female HIV prevalence. In regards to poverty, a 1 unit increase in percent living in poverty resulted in a 2% increase in overall and male HIV prevalence, and a 3% increase in female HIV prevalence. For the proxy spatial variable, a 1-unit increase in distance to the city center, which is, again, looking at this issue of clustering, resulted in a 3% decrease in overall in male HIV prevalence and a 2% decrease in female HIV prevalence. So this confirms this issue of clustering of HIV. So the further you're away from the city center, the lower your HIV prevalence is. And then for black population, a 1-unit increase in percent black population translated into a 1% increase in overall male and female HIV prevalence. Looking at our looking at our prison release rate variable, a 1-unit increase in prison release rate resulted in a 4% increase in overall HIV prevalence, a 3% increase in male HIV prevalence, and interestingly, prison release rate was not significantly associated with female HIV prevalence. So there are a number of limitations in this data. Those of you who do geospatial work or who look at this type of data, you probably realize that I did use as our outcome HIV prevalence versus incidence, and that was largely because that data wasn't available at the time. We now have incidence data for 2013. We have it within the last few weeks, and we're working on re-looking at our models. However, this is exploratory, and we feel like there's some association here, and I think that it's worth some concern and some interest. We also looked at the issue in terms of the geographic boundary of the zip code. And as you all know, zip codes are very large. Do they really define a neighborhood, or are there many neighborhoods within zip codes? The problem with surveillance data is that you cannot get it to a more granular level than the zip code. It's just not available for most health departments. The CDC doesn't give that information out. So we had to look at the data at the zip code level. The other issue that's of interest is that we looked at prison release rate. Remember, I told you that people stay in prisons for a longer period of time than they do in jails. People cycle in and out of jails quite rapidly. So could we look at jails and find some interesting information, and are there interventions at the jail level that really need to be implemented? So in terms of next steps, like I said, we're looking at HIV incidence data, and we're looking at that data in 2013. We're actually doing an in-city spatial analysis. When you look at data across a number of cities, it's very difficult to look at sort of the granular issues and get a better sense of actually what's really happening at prisons and jails on a local level. And then we also want to stratify the analysis by risk group. Look at MSM. We've already spoken about the particular issues related to black MSM, and kind of get a better sense of whether or not this is an issue that needs to be addressed that would affect that particular risk group. So even with those limitations, I think that some conclusions can be made. On a population level, HIV prevalence is most highly correlated with economic inequality, and this has been noted in other studies. We know that clustering of HIV prevalence occurs in certain parts of cities, and that indicates a place-based effect. HIV, again, doesn't occur randomly, and again, that's been noted in other studies. But what's unique here is that we found that prison release, and this probably due to the lack of discharge planning, is an important population level factor with a significant association with overall as well as male neighborhood HIV prevalence. Interventions for incarcerated populations are needed, particularly upon release, but I think if you go back to the model, there are a number of areas where interventions could be implemented. And I strongly believe, and this is more a larger comment just from my standpoint, getting to zero is going to require more than a biomedicalized approach. I mean, we have to pay attention to these structural factors, like the economic structural factors, but also with mass incarceration, I think we're missing a large population who are at high risk of HIV infection and onward transmission. And particularly with mass incarceration, I think unlike some of these other large structural factors where you feel like you can't really do much about them. I mean, what can you do about income inequality in most places? There are specific targeted interventions that one could do that could decrease the risk related to mass incarceration across the US. So I want to acknowledge Patrick Sullivan and Eli Rosenberg, who participated and helped with the analysis for the study, as well as the Behavioral and Social Sciences Corps here at Harvard and the National Institutes of Mental Health, who funded the study. So before I let you go, I just want to say something about the National Survey on HIV in Black Americans, because I think that's important. I have a little bit of time left. So even though a lot of progress has been made, HIV continues to disproportionately affect Black individuals. Here at the Harvard CFAR, we developed this Health Equity Scientific Working Group to support novel areas of research. We also instituted a National Advisory Committee that's the membership includes 4 Harvard CFARs, UCSD, Penn, the DC CFAR, and then ours. the NAACP, government, CBOs, and faith leadership. And our primary goals within the National Advisory Committee were to identify priority areas so that we could move a research agenda forward. So we looked at lots of different research areas and research areas that were related to specific risk groups, particularly Black MSM, and we decided we need to take a step back and we need to kind of look at what is really driving the epidemic and why is this wide disparity exist and why has it persisted over time. We wanted to focus in on structural factors, as I've already mentioned, but also cultural factors, or the range of ideas and beliefs and activities of a group with shared values, like issues related to the Black church, issues related to homophobia or homopositivity, transphobia or transpositivity, whatever it is that's existing, and then gender dynamics. So we realized that additional data is needed to better understand and fully characterize those factors, and we decided that we wanted to do a national survey to actually focus in on some of those structural and cultural issues, and to administer that survey to a nationally representative sample of Black individuals across the US. So I know probably those of you in the audience who do a lot of this work think, well, there are lots of national surveys, what makes this different? Well, it is different. So there are a lot of standard variables that we asked about, HIV risk behaviors, HIV testing, and demographics, which is similar to like BRFSS, for those of you who are aware of that, the Behavioral Risk Factor and Surveillance Survey. But then we also ask about a lot of structural factors, lots of things that we don't always think about are related, but they are very integrally related to our behaviors and our risk. We asked about mass incarceration in the criminal justice system, particularly looking at issues like police brutality. We looked at racism and discrimination, as well as colorism or discrimination based on skin tone. In terms of stigma, we looked at homophobia, as I mentioned, but also transphobia, because that's not something we collect a lot of data on. And then lastly, just a research interest of mine, this issue of immigration and how we don't collect data on country of origin, though the Black community in the US is not homogenous, and we need to understand people ethnically and the diversity within the community. So the administration of the survey is completed. It was completed a few months ago, and we have a nationally representative sample of 900 individuals. So there are a number of papers that are in progress currently. I would encourage you, I put my email there, if you are interested in looking at this data, we would like to work with emerging investigators. A lot of these papers are currently being written by folks who have been involved in the National Advisory Committee, but we're open to collaboration. And we're going to reveal a lot of this data around World AIDS Day, and that's sort of why I didn't present it here today to you guys. But I want to also, just because I have the floor, I just want to acknowledge the folks who are a part of the National Advisory Committee and who provided a lot of assistance and encouragement during this process, particularly Wanda Allen, and also my mentor Ken Mayer, who, even though he wasn't initially involved, became involved because I said, you have a lot of experience, please help me. And he just jumped right in. So, and that's just Ken. So that's it. Thank you.
Because of time constraints, we will entertain one question, and you will be able to talk to the speaker later on.
Maybe two.
Oh, maybe two. Well, they're already. Go.
I'll start. Dick Chason from the Hopkins CFAR. The data on prisons, I think, is very important, and there are clearly clinical and transition clinical care issues related to prisons. But I think it's also important to think of prison as a marker of socioeconomic status of race and so forth. Mm-hmm. And a number of years ago, when we looked at TB infection in drug users in Baltimore in the ALIVE study, we found that having been incarcerated was a risk factor for infection. But we also found that having ever been arrested, whether or not you were in prison or spent a night in jail, was equally a risk factor. Mm-hmm. So we blamed it on the police. But I think it's a marker more than an environment. The environment's important, but it's also a marker.
Absolutely. I think with these spatial studies, it's very complicated. The relationships between these factors are multifactorial, so that's an important point.
So just a quick question about prisons and whether are there any prisons that are sort of leading the charge in terms of innovative ways to reduce risk within the incarcerated population?
So I can't identify a specific prison, but there are several demonstration projects that have been going on for several years. There's the Enhanced Link project, and then there's another project that wrapped up around 2011, which was specifically looking at linking folks from prison into the home communities. They're both funded by HRSA and CDC, and they both did a great job. It's just maintaining a demonstration project. You know how that just doesn't happen all the time, and that's what's going on right now. So thank you.
Okay, our next speaker is Dr. Hyman Scott He was the clinical research medical director at Bridge HIV in the San Francisco Department of Public Health, and also an assistant clinical professor of medicine at UCSF. And his topic is determining HIV acquisition risk factors to better target prevention modalities.
Hi, good morning, everyone. Thank you for inviting me to talk today. So I'm going to talk about risk factor determination and a new risk model that we've created called SexPro. So I'll talk a lot about sex today. I have no disclosures. And we had some discussion earlier about the disparities that we see in the U.S. Among our epidemic. And it's highly concentrated among MSM, as we've discussed, and also significantly associated with race ethnicity, with a higher proportion of black individuals making up the diagnoses in the U.S. And as you can see, these disparities appear to be worsening. And NHBS has also presented some data that this worsening is actually occurring most among young black MSM under the age of 24. And we've seen, as we've seen PrEP roll out, the potential for this worsening these disparities, as these are data that were presented from Gilead of PrEP uptake in the US from 2012 to 2015, and 74% of those users are white, and 10% were African American, whereas the estimated new infections are 44% among African Americans and 27% among whites. So we have this worsening disparity in our efforts to increase uptake of these efficacious prevention interventions. And in San Francisco, we're also monitoring PrEP uptake and persistence. Among our primary care providers, we have 18 primary care clinics spread across the city that are embedded in neighborhoods, and we are monitoring PrEP uptake and persistence among these clinics. And overall, persistence is around 67% for individuals remaining on PrEP. We didn't see any differences by gender or age, but there was significant differences between clinics. What's most concerning is that we see, tremendous racial disparities, with African Americans having 50% persistence with a median duration of 4 months, compared to whites 68% with 12-month duration. So to implement these efficacious HIV prevention interventions are going to require a lot of efforts to increase uptake and persistence. And one of the elements of uptake and persistence is understanding an individual's risk for HIV, both from a provider's perspective as well as from a patient's perspective. And among MSM, the data suggests that MSM underestimate HIV risk. So this was a young men's study. 74% of the young MSM perceive themselves at low risk for HIV in their lifetime. However, 47% of those individuals reported over 20 lifetime partners, and 32% had more than 4 partners in the last 6 months. 21% were diagnosed with an STI, and among this group who saw themselves at low lifetime risk, there was 6.4% were actually HIV infected and unaware of that infection. And a CDC web-based survey also looked at 946 MSM, and about a third of them also reported being low risk. However, 35% had used non-injection drugs, more than 50% had more than 2 partners, and 37% reported non-condom anal intercourse. So what we have focused on is developing a patient-focused HIV risk assessment model and implement it on a user-friendly platform that could support uptake and persistence of these HIV prevention interventions, both for patients and for providers, and ensuring that it applies to a diverse cohort of MSM so that we can work to scale back these disparities that we're seeing expanding among MSM in the U.S. So in order to develop this model, we looked at what cohort data we have available. Explore was a behavioral intervention that was enrolled in the late 90s, early 2000s. It was 4,000 participants, over 22,000 visits, and 217 HIV infections. And Vaccine Vax 004, which was a vaccine study in the late 90s, also almost 5,000 participants, 25,000 visits, and 343 infections. And these cohorts are from the late 90s, early 2000s, and our epidemic has changed since then. So we wanted to validate in more contemporary cohorts. So HVTN 505, which was a vaccine trial that enrolled in 2009 to 2013, with over 2,000 participants and almost 11,000 visits. And then HPTN 061, which was the largest longitudinal cohort of black MSM in the US in 6 cities. And it was an observational cohort that was testing the acceptability and feasibility of a multi-component intervention. We, using these data, we used a pooled logistic model for seroconversion, using the sexual risk behaviors for the last 6 months and ascertained at the 6-month intervals before HIV testing, and fitted these conversion risks to a 1 to 20 scale, sort of analogous to a credit score. So the higher the score, the higher the protection, the lower the score, the higher the risk. And so these are the models, these are the predictors that came out in this model. So for the demographics, age under 35 associated with HIV infection. Black race, self-identification of black race was associated with a large odds ratio of 2.4, and Latino ethnicity 1.54. As far as risk behaviors, so non-condom receptive anal intercourse, these are episodes with positive or unknown status partners. We did see a plateau after 10 partners, 10 episodes. So between 1 and 10 episodes, increased risk of 1.23. Condom protected receptive anal intercourse with positive or unknown partners. And then we saw this protective effect with HIV, having one HIV negative partner for risk of HIV seroconversion. Heavy alcohol use, meth use, popper use, and STI diagnosis, self-reported, were all associated with HIV acquisition in this development cohort. When we looked at how well these models fit our observed HIV seroconversions or HIV infections in these cohorts in Explore, which is the internal validation, we saw a good model fit. And then in our initial external validation with VAXA-04, we also saw a good model fit. With C statistics of 79.5, a C statistic of greater than 70 is associated with good model fit, and we saw a good model fit for both of these cohorts. In comparison, when we looked at it in our more modern cohorts, so 505, we also saw a good model fit with a C statistic of 71.9. In HPTN 061, we also saw a C statistic that was greater than 70, reflecting good model fit. So we have tried to move this from into a user-friendly platform. So this is the website. This is a mobile-friendly website. It's called mysexpro.org, and it is available freely online. And it really is focused on being used in the setting of combination prevention to target, for example, PrEP. So providing users with an ability to see how PrEP might increase their reduce their HIV risk and increase their HIV risk protection, and being used by providers and by individuals to better assess their risk, so that to hopefully increase uptake among those who are at risk for HIV in the U.S. So I'd like to thank all of my collaborators, and in particular my primary mentor, Susan Buckbinder, and thank you for the invitation to talk.
Good. Well, we can use some of your time to have a few more questions.
Sure.
Morning.
Hi, Chris.
Great talk, great work. So I've been thinking about this myself, and you think a lot about this because you're now kind of in the business of trying to increase PrEP uptake. And so I'm just wondering, because you're trying to target the highest risk individuals, and the SexPro might help to do that, what's your collective tolerance level for number of infections among people that are prescribed PrEP? Because, you know, that's going to happen. And so I'm just wondering, as a group, how do you know whether the intervention is working relative to the general sort of pool of at-risk folks? So what's your collective thinking on that between you and Susan and the health department?
So just to make sure I understand, the collective tolerance for HIV infections among individuals
Right,
who initiate PrEP?
you're going to be initiating PrEP,
Yeah.
and some men or women might still get HIV infected.
Yeah.
not because the product doesn't work, but because, so I'm just wondering how you're going to track that, and at what point you sort of say, what's an acceptable level of infection?
So our approach is, we are monitoring and we work collaboratively with surveillance. So within our cohort, anybody who seroconverts, we're made aware of that seroconversion very early. And then our integrated partner services reaches out to those individuals and explores the issues of adherence or access. I think we're seeing a lot of people falling off of PrEP because of insurance churn. So we have a lot of individuals who are on Medi-Cal, and every 6 months you have to renew. And if you don't respond to that letter, you just get dropped. And when you go to pick up your meds, they're just not filled by the pharmacy. So those are really identifying the gaps and the holes in our system that we need to address in order to increase uptake, particularly among the most vulnerable populations. So younger individuals, individuals who have competing needs in their lives, they're not going to have the tolerance for the hassles that are necessary to continue on PrEP, which is sort of what we want them to have. And also working to find people, to allow people to enter PrEP wherever it works best for them. So the idea that every door is the right door, and that we want primary care providers to be comfortable prescribing PrEP, but those aren't the only providers that we want to be comfortable. So Planned Parenthood, working in our STD clinics, Strut, which is the CBO, and the Castro also offers PrEP as well, and integration into some of our youth clinics, for example. So a variety of places where people can access PrEP so that we can break down some of these silos that I think are keeping the most vulnerable people out of our prevention targets.
Ken Friedberg from the Harvard CFAR. Really nice example of how you can use data from the last millennium to understand some really interesting issues. I'm wondering if you've taken your predictive model and applied it to the CDC recommended population who may be PrEP eligible to see if you could distribute those 1.2 million people that Doug showed us across your 1 to 20 spectrum, and see really where the where the highest risk group and how many there are there, and try and do that matching.
Yeah, I think that's a great idea. We hadn't really discussed applying it in the same way that the CDC. The predictive model, when we've discussed it with Dawn and her statisticians, it has similar predictive capabilities from the models that they've developed. But that's an excellent suggestion. We should definitely pursue that. Thank you.
Hi, I'm Amy Nunn. I'm from the Brown. What are we, Susan? The Boston. Providence,
CFAR.
Boston, CFAR, sorry. Our name has been evolving. My question is actually for Bisola. Is that out of bounds? Is she around? Okay. Oh, great. Okay. So you highlighted how mass exodus of African American men and mass incarceration is having detrimental impacts on our epidemic. So what do we do about it? Is the answer to intervene when people are in the correctional system when they're released, or do we need to have another good look at our correctional policies? Then I have another question. I'm co-leading the faith working group for the intra-CFAR, the new faith working group, along with Michael Kiefer. And we have, and this isn't for Bisola, this is for anyone from NIH who wants to respond. We've tragically overlooked a lot of the social and structural factors that are contributing to our alarming rates of disparities, including mass incarceration, including neglecting to engage the faith community in our response to HIV prevention. We've been really successful at engaging faith leaders, both in inner city communities in the Northeast as well as in the Deep South in Jackson, Mississippi. There's great work happening at the University of Alabama, at Rand, also in Kansas, pockets around the country. But one of the problems is there's not any NIH money being dedicated to this serious issue. Where's the NIH on this, and what do we do about it?
This is great discussion for the panel. Could we have questions for our speaker?
Okay, so Bisola, and then maybe y'all can address the subsequent question later.
Save it for the discussion, okay? Thanks.
My question was also for Basola's.
Oh.
Yeah, that's
Do you have a question for our speaker, Ron?
I guess my question for the speaker would be kind of to follow up on his question. Is there a room to use the sex pro model and some of the current PrEP studies that are happening? Is there some kind of way that we could tie that in to what's existing right now?
So yes, and that's sort of the whole, was one of the reasons we developed it in the way that we developed it. So it is currently being used as a screening tool for HPTN 083 as one of the inclusion criteria. So having a sex probe below a certain cutoff identifies an individual at high risk that might not be reflected in our standard risk assessment. So we're seeing a lot of HIV infections among Black MSM, for example, despite similar or lower reported risk behavior. So those risk questions might underpredict the HIV risk of our most vulnerable population in the US. So it's being used in HPTN in that way. It's being used in our PrEP uptake interventions in San Francisco that we're working on. So it's, and the idea is that it would be used to help target individuals who might benefit from PrEP.
And I just
Okay,
need I need the Penn CFAR credit that Bruce was talking about.
Okay, great. Quick question, Ron.
Ron
Right, quick
Swanstrom,
answer.
UNC Chapel Hill CFAR. Who's the target audience? Is it the caregivers, or is it actually people who are at risk? And how do you market to those people to get them to actually use it at a high frequency?
So the target is really both. It's meant to be easily accessible and, for example, could be done by a patient in a waiting room, for example, and shared with their provider. And as far as targeting, I think we've had a lot of success using sort of the gay social networking apps, such as Grindr, Scruff. Manhunt had seen this, seen SexPro in its early development and was interested in using it among its users on its website. So those are the areas I think that we would first start with and then try to expand. In one of our, in a couple of our studies, a lot of the men that we work with are very well connected socially. And so we had 2 participants who we didn't know they knew each other, and they were in our study, and they would check their SexPro scores before they went out drinking, and whoever had the lowest score had to buy the first round. So there was this social spread of sort of people wanting to use it, and they would share it with their friends. And so using the social networks to leverage communities and populations that we are otherwise not going to have contact with. These are generally healthy young men who might not be in medical care for any reason because they don't have any conditions that require regular follow-up. And so it's an opportunity to leverage and engage in a more social, user-friendly way some of our prevention modalities.
Great, thank you very much.
Our next presenter is Dr. Abigail Batchelder. She is a clinical and research postdoctoral fellow at the MGH and part of behavioral sciences research program at the Fenway Institute. She will be talking on developing social behavioral interventions to address HIV-related, health-related behavioral change.
Thank you, and thank you for having me, Harvard CFAR. So I'm going to talk to you about developing social and behavioral intervention strategies. So I'm not going to give you as much data, but I do love talking about this. So if you'd like to hear more about data related to any of these things, I'd love to talk to you afterwards. So among the over 36 million people impacted by HIV around the world and 1.2 million in the United States, we see discrepancies or disparities among populations. And these populations like MSM or African American and Hispanic women have different needs, but there may be some underlying common denominators in terms of barriers to care. And I'm going to talk a little bit about both. But I think it's really important, anytime we think about addressing barriers to engagement in HIV treatment, to think about an ecological framework. So any individual living with or at risk for HIV is living within the context of structural barriers, like we heard about from Basola, as well as institutional healthcare barriers, community barriers, interpersonal barriers, and individual level barriers. And I'm a clinical psychologist, so I tend to focus on individual level barriers like depression. But I'm also very mindful and aware of the way the other barriers interact and impact the individual. So I think a lot about the internalization of stigma and the internalization of stigma related to lots of these barriers around being MSM, being a substance user, living in poverty, being marginally housed, etc. And we know that these barriers don't work alone, right? They interact, and Meryl Singer, a medical anthropologist in the mid-90s, originally described syndemic theory as this idea of afflictions that interact synergistically to perpetuate disease burden upon vulnerable populations. And he originally described the SAVA syndemic, substance abuse, violence, and AIDS, and many since, including Ron Stahl, who published a seminal paper in 2003 in American Journal of Public Health, talked about an additive framework. And he added childhood sexual abuse and intimate partner violence, as well as polysubstance use, to look at this additive framework. And many others since have repeated this methodology in other samples, including many from MGH, as well as other institutions, Mustansky, Parsons, et cetera. And I've actually looked at some of these variables with regard to women, thinking about maybe it's not additive, but maybe it's interactive, maybe it's multiplicative. And some of that work also generated, I think even more importantly, I developed a simulation model looking at a cohort study of women with an at risk for HIV, but I ended up working with a CAB on that project, a community advisory board, and I took the ideas to them and asked them what they thought about the hypotheses. And what I think is one of the most fruitful pieces of that work was that they said, you're missing something, Abby. Like, yeah, these things hang together, we get it, but self-worth is really important. Self-worth is part of the syndemic framework. And after research, subsequent research, I've come to think about self-worth as potentially the internalization of stigma, which I'll tell you more about. So I also think I just want to touch on, I feel like as we think about syndemics and co-occurring barriers, I want to think about comorbidities as well. I've done some work in diabetes and HIV, Hep C and HIV, and even some neurocognitive and psychiatric issues in HIV. And I think those are important to think about. But bringing all that together, thinking about an ecological framework, syndemic, so things interacting synergistically, I think about the HIV Care Cascade. And where can social and behavioral science intervene? What can we do to help? And I actually think we can help at every point along the cascade, even starting with prevention, testing, linkage to care, retention and care, initiation, adherence, and ultimately reaching viral suppression. And I think an important point is that as people dip off on that care cascade, the reasons that they're dropping off are often behavioral, right? So I think about treatment as prevention. Great strategy, doesn't work if someone's not taking their medication, which is a behavior, right? And we as social and behavioral scientists are good at thinking about interventions for adherence and other behaviors. So over time, many social and behavioral scientists have focused on adherence, myself included, and we've been successful. For example, we've found that depression and adherence are related, and we have robust evidence-based interventions to address depression and adherence together. Steve Safran, who was at MGH and Fenway, developed CBT-AD. Now, myself and some other social and behavioral scientists are starting to think about how we can use what we know to address engagement across the HIV care cascade. And some open pilot work that I've done at UCSF and I'm hoping to do here at MGH, I'm going to tell you a little bit about, as well as some pilot work that Connell Cleary's doing, my mentor here. And of course, there are others. So as a social and behavioral scientist, and particularly a clinical psychologist, we have a toolbox, I would say a fairly robust toolbox of intervention strategies that we know to work, empirically based, somewhat brief, depending on who you ask, intervention strategies that we can utilize, adapt, and I would say, move around in a way that can address barriers to engagement and care across the cascade. And there are lots of them. So currently, there are various evidence-based or moving towards evidence-based intervention strategies from many social and behavioral scientists, including addressing mental health barriers, substance use barriers, HIV prevention strategies or sexual health, and even some that are specifically targeting the interaction of barriers to engagement and care, syndemics. So I want to tell you a little bit about my current focus. I trained in the Bronx and did some qualitative work, mostly focused on people who use substances with an at risk for HIV, as well as Hep C and some other issues. And then I went and interned at UCSF and did a year postdoc there, where I got a pilot award to investigate my thinking based on work that I had done previously. And then I ended up coming to MGH in the middle of the postdoc. But essentially what I had found and heard over and over again from individuals living with substance use disorders and HIV is that when they felt bad about themselves, when they felt less than, when they felt internalized stigma, I would venture to say, they said, I'm not taking my meds. I'm not going to my appointments. I feel too bad. But when I feel good about myself, when I feel okay, I'm going. I'm engaging in the treatment. And that was something I heard so often that I really began to think about it critically. And I started to think about what was the mechanism of action. And as a psychologist, I was thinking about affective science and internalized stigma. And the affective correlate of that is shame, and shame elicits an avoidance response. We know that. We have animal models for it. And so what can we do to address that potential mechanism and test it, right, to see if this is accurate? So in the first couple months of my postdoc at UCSF, I got the CAPS Innovative Pilot Early Investigator Award and ended up doing qualitative interviews with providers, case managers, and patients, asking them what they thought about these ideas, asking them what they thought about some evidence-based components that might address these ideas. If we break it down, we have evidence-based components that address avoidance or that are trauma-informed, et cetera. And leaning on theory, the stress and coping theory, I developed an intentionally brief and what I would call low-cost intervention, thinking about the contextual framework, those ecological barriers, right? We can't have too many sessions. We can't have, for the people I was working with in San Francisco, we couldn't have an app. A lot of people had government phones, so we used text messaging. So I developed 5 individual sessions coupled with bidirectional text messaging that was informed by CBT. The text messaging ended up modeling cognitive restructuring. We had people come up with compassionate self-statements that were sent back to them in a way to model compassionate self-reappraisal, if you will. People had things like, I'm more than just a junkie, or I deserve to take my medication, things like that. So I ended up piloting this in San Francisco, and I was fortunate that they enabled me to continue to finish the study after I came to Boston. But I ended up getting 9 people to complete the pilot. And the challenge here, and what I see as the major outcome, is that this was feasible. These were polysubstance using individuals who were mostly marginally housed, engaged in various risk activities, but they're all HIV positive, and I got a lot of pushback saying, these guys are not going to engage in this intervention. They're not going to respond to your texts. And they did. 8 out of 9 people completed it. Over 70% responded to we got an over 77% response rate to the text messages during the face-to-face component, and a 70% response rate to the text messages for 2 months post face-to-face sessions. So these guys are on their own. And we actually had over half of the participants, which is a small number, admittedly, asked to keep getting those text messages. They really liked them. They liked that they were in their own words, that they were empowering, etc. So when we asked in terms of feasibility and acceptability, I asked, how likely are you to recommend this to a friend who uses substances? We got a really high response, 0 to 10, 10 being definitely. Our mean was 9.7, and our interquartile range was actually 10 to 10. So the vast majority said, absolutely, yeah, we want to keep doing this. We would recommend it to friends. I'm not presenting the outcome data because it's only 9 people, but I can tell you it looks promising enough, I think, in terms of improving engagement and care and reducing substance use, not getting rid of it, but reducing it. That's, I think, way too ambitious for a brief intervention like this, but that it's enough to try to test and see what this looks like in an RCT. So what I'm hoping to do, I'm a postdoc and I'm waiting to hear back on a K23, but I'd like to investigate rigorously the mechanisms related to stigma-related emotion. As I said, from an affective science perspective, shame, which I would call the emotional correlate of internalized stigma, elicits an avoidance response. It makes you want to hide. So I would hypothesize that may mediate the relationship between internalized stigma and engagement and care, and then run an RCT after doing focus groups, particularly with men who have sex with men who are substance using and HIV positive in Boston. During the pilot work in San Francisco, we got more than half of our participants were MSM, and it became clear that homonegativity was an internalized stigma that we needed to account for. And on that note, I'm also hoping to get some additional support to start to look at intersecting internalized stigmas and investigate how they relate to engagement and care among individuals with 3 specific intersecting stigmatized identities, being HIV positive, a substance user, and MSM. And I want to thank everyone. That's it. I want to thank Connell O'Cleary, my mentor here, and Ken Mayer, as well as others in San Francisco and elsewhere who have helped with this work. And I would like to, take any questions. Are there any questions?
Susan Buckbinder from the San Francisco
Hi.
CFAR. And this was great, and I do think that one of the biggest drivers of our issues with trying to get people into care and into prevention is internalized stigma and shame. And so I guess what I was going to ask you is, we were just at the R4P meeting, and somebody got up and asked a question of one of the speakers about what do we know about the range of stigma interventions. And there really wasn't much that was said because it didn't seem like we have much. So I guess it would be really great to hear what's your sense of the range of stigma interventions that are being tested and tried in addition to what you were trying?
Yeah, so there are a few, but there aren't many. And as a clinical psychologist, I feel that, if we can unpack mechanistically what's happening with the internalization of stigma in terms of poor engagement in care, we may be able to address that. There are some, I would say, multi-level or other level interventions, thinking about provider level stigma interventions that I think are useful. And ultimately, I would say we need a multi-level approach because, you can help the individual and then they go back to a stigmatizing environment. But I think helping the individual is important too. So I think there are some that are emerging, but not many. And I think to lean on what we know in social and behavioral science may be an effective strategy.
Well, it's great you're pushing forward with this. Thank you.
Thank you.
First of all, I want to thank you for doing this. My name is Andre Ford. I'm with the University of Pennsylvania. I'm the chair for their Community Advisory Board as well as the national chair.
Cool.
Maybe I missed it, but is this set up for young?
No.
Okay.
No, it's
so
not specific.
When you're talking about text, receiving text, I know I'm an older gentleman. I don't follow my texts all the time. My son just texted me. I told him I'll reach out to him later. Okay. How are you handling matters when you're dealing with an older MSM or a person who doesn't follow those? Because some of us, some human beings, I should say, are inspired by face-to-face conversations.
Well, absolutely, and that's exactly why I included the 5 sessions. So I wanted to develop something that could be at least moved forward that might be implementable, right, in low-resource setting, low-resource community clinics in the U.S. specifically. So there is that 5-session face-to-face component, which I think is really important, and we hear that in research that exists, right, that beyond just text or apps, face-to-face contact is important. I did do quite a bit of research looking at the proportion or prevalence of phones that have text message capacity among different age groups, and it's more than you would think. A lot of people are using texts, and so that wasn't actually a barrier. We did ask about that in qualitative interviews as well. We had, I think, thinking about tech literacy as an important variable. I think text messaging is a little bit easier than apps in that regard.
Thank you.
Sure.
So Carlos Del Rio from Emory CFAR, great presentation, really interesting.
Thank you.
I think, one of the issues around text messaging, and I caution people because text messaging is an intervention that has been proven and used quite significantly in Africa, but that's because text messaging in Africa, if you receive a text, you don't pay for it. In the United States, there's a structural barrier, which is you pay for text. And actually what we found is that when people ran out of minutes, then you can't text them. And so a structural intervention is to get the phone companies not to charge poor people to receive text.
Yes, no, absolutely. And in fact, I went through great lengths to get a key card, essentially, to pay into people's cell phone plans to prevent running out of minutes. And I think there are ways that clinics could, if this is useful in a real, randomized control trial, if we get there, then I think there are ways to pay into plans to prevent that from happening. It's really pennies to receive a text.
Poor people, many places are getting cell phones that are called Obama Obama phones.
Yeah,
And the
government
problem
phones.
with the Obama phones is that you have the phone and then it runs out. So people have multiple phones.
Oh, I know,
And
yeah.
not one phone to text them into. And in
Yeah.
fact, we did a study that just got accepted into J showing that one of the predictors of falling out of care
Yeah.
is having multiple phones.
Multiple phones. Okay. Indicative of, okay. Well, so I mean, in the open pilot, I also budgeted for additional support to buy additional phones because we had, I think, at least half of the very small sample.
But we need retention of phones.
No, I know we need
Retention of numbers.
or an ability to buy another phone for people. I mean, government phones are not terribly expensive. Yeah, Connell.
I just wanted to provide something of an antidote to the emphasis on text messaging as part of the intervention that Abby has designed here. One of the slides that I really liked that you put up there showed the kind of dose that's required in these interventions to change well-ingrained behaviors that are predicated on mental illness or serious dysfunction or distress. And I think interventions that address stigma are correctly perceived within the context of trauma-informed care. Yeah. And the kind of dose that's required to address trauma-related impairment and distress, including the extent to which it interferes with appropriate engagement in HIV care, in the clinical psychology field, is somewhere between 10 and 15
That's
sessions. Right. And I know for those of us who are involved in public health, we're trying to broaden our reach, our gaze, our penetration, and we're consistently grappling with the issue of scalability, and that focuses our attention on easily scalable intervention components like text messaging. But I think when you're talking about stigma and treating stigma, particularly intersecting stigmatized identities like in your work, I think we really have to get real about the dose that's required, and we have to modify our thinking on scalability and thinking about focusing in on the specific groups that we're working with.
Oh, absolutely. And just to that point, and I know my time, so the intention of the text component, we're not just asking people, are you adherent and how do you feel and are you using substances? The text component for the 2 months post the 5 sessions is a bidirectional text component that mimics what you might get in a cognitive restructuring interview. And that's the novel part. And I didn't go through this here because I was asked to talk about development of interventions. But the texts themselves, we're asking people to come up with these reappraisals based on stress and coping theory, probably the most widely cited and accepted theory on stress and coping. We're asking people to come up with these compassionate self-reappraisals based on the 5-session content. So they develop things like, I'm worthy of taking my medication because I'm more than just a junkie, or I deserve to be healthy. These things that are informed by the content of the evidence-based intervention, content. And then we ask them to pair them in the end of the 5 sessions with the emotions that they think those statements would be most helpful in regulating and helping them move forward to attain their HIV-related goals. And then every day we ask them, how are you feeling? And based on their response, we send them back their statement that they've developed based on the content of the intervention. So the goal here is very thoughtfully thinking about the duration of treatment for therapy. We know that we need X amount of time. That's hard to fund, right? And it's really hard to fund for people who are actively using and people that think are the high-risk group that we can't ever attain, right? But my idea essentially was that if we can extend the benefits of the intervention using this relatively low cost, assuming people can keep their phones, text component that mimics and that reminds people of the intervention content, then we might be able to do this at a lower cost and in a more sustainable way. We have to test it, obviously, and I'm hoping to be able to do that. But I'm very thoughtful about the duration issue from a clinical psychology perspective. And then I have a background in public health, so I'm also thinking about sustainability and implementation and what people will really fund.
Well, thank you very much. I think we would like to call our panel members to come and join us here.
And while the panelists are coming up, if you have questions that you're ready to ask, why don't you line up at the microphone so we can keep moving because we're really running late.
And we would like the panel members to introduce themselves.
I'm Susan Buckbinder from the San Francisco Department of Public Health.
Kevin Cranston, Massachusetts Department of Public Health.
Connolly Cleary, the MGH, and the Harvard CFAR.
Don't see anybody but Amy, if you wanted to address your question, because it was more for the panel rather than for an individual speaker, I think. Just, I think we heard most of it, but you might just.
Sorry, I spoke out of turn. Y'all know I do that habitually. Amy Nunn from the Brown, I'm sorry, Vicky's correcting me, the Providence Boston CFAR. I wanted to ask any of the NIH program officers to comment on the urgency of addressing the role of the faith community in potentiating or mitigating HIV disparities. This has historically been an area that's been overlooked, and it comes up again and again, the role of the faith community in our nation's HIV epidemic. This is also important for the intra-CFAR working group that we're leading with the Rochester CFAR. We'd like to just hear what you all think about that, and how can we work together to advance the science to better engage clergy and faith communities in the response to HIV. My other question was for Bisola about the appropriate interventions to address the correctional crisis. Do we intervene at the structural level, or within the correctional system, or with people upon release? How do we tackle the problem?
So maybe we'll ask our panels, anybody to, comment on Amy's issues that she brought out, and then maybe people from NIH can also answer.
Well, I'll just speak to the issue of the faith-based community, because I think it is critical that faith-based community plays a critical role in many people's lives, and particularly in some communities of color. I know that Mike Kiefer has worked really, and I don't know where he is right now, but has worked really closely with Reverend Edwin Sanders, who has an initiative through the HIV Vaccine Trials Network to try to work with various faith-based communities, and we've been working in Oakland with him to try to engage a variety of different churches. It has to be more than just, oh, well, we've got this faith-based initiative. It's a huge community. Some people are more receptive to talking about sex and talking about substance use and talking about other things in non-stigmatizing ways than others. And it's a huge challenge, and I think it's a really critical piece of what it is that we do. And so I'm really glad to hear that initiative moving forward. I can't speak on behalf of NIH, but I can say that at least this particular initiative has been funded through HIV Vaccine Trials Network.
This is atypically one place where my academic preparation actually does prepare me to respond. Amy, you and I have discussed this. In fact, standing in line at the White House, I think we had this conversation. I think it's a mistake to lump faith communities into one bucket. I think we really have to be very thoughtful about the ways in which churches, mosques, synagogues, temples, and other congregational organizational structures can and cannot support our goals of HIV prevention and access to care. Having said that, we in Massachusetts and around the country have made extraordinary efforts to engage faith leaders as moral voices in their communities, as organizing principles to bring together their congregations around particularly HIV basic awareness, HIV screening activities, compassionate care strategies. But I think we have to wrestle with the dilemmas of a number of faith communities' own moral theological positions are in themselves stigmatizing and traumatizing to members of their own congregation and larger communities. So that's always a push-pull in these dialogues.
I would just add to that as a clinical psychologist who's primarily focused on looking at mental health and substance use barriers to sustained and appropriate engagement in care, I think as people are disengaging from care as a result of mental health issues, be it through depression-related withdrawal or anxiety-related avoidance, particularly traumatized groups, we find that isn't the extent of their disengagement. They disengage from families and friends and from the whole range of support communities.
including the kinds of supports that they had traditionally accepted and received from faith-based organizations. So politically agreeing with both of what the previous panelists said, I think it's a key issue and can really help broad-based re-engagement to support mental health and its barriers to HIV care.
May I answer Amy's question? She asked about criminal justice reform and the question regarding interventions. Thank you for that question. I think it was really important. So I think HIV is one very small component of criminal justice reform. You know, we squander human potential in this country by sending so many people to jail. Obviously, from an HIV perspective, we can look at discharge planning, which we already talked about. We can certainly look at increasing the rate of opt-out testing, increasing the list of HIV prevention strategies that are available to people, whether they choose to engage in activities or that they're forced to engage in activities. But the bigger issue is keeping people out of jail. You know, when you look at this reduction in opportunities, economic opportunities that people experience when they, you know, have this incarceration history, as well as things like PTSD, low self-esteem, psychological distress, loss of understanding of what's normative behavior from being incarcerated for such a period of time. I actually know people who look at incarceration and call it college or university in the Black community, and that's not appropriate. As a society, that's not appropriate. So I think it's just one small piece, and you know, I think that it's easy from a structural standpoint, as I said before, to address those small pieces, but it's a much larger societal issue that we have to deal with.
Hi, I'm Brian Bastiansky from the Third Coast Center for AIDS Research in Chicago, getting us on the board with a question. So my question is about PrEP discontinuation. And I think, you know, when it comes to HIV prevention, we've not necessarily ever done a good job of helping people think about discontinuing a prevention approach. So when it comes to condom use, the message has always been, when that was our only technology, when someone would ask, when can I discontinue it, the answer was never. When we did interviews with young MSM in Chicago about what have you heard about when you could stop using condoms in a relationship, the answer is I've never heard anything about that. And so they just kind of make up ideas about when is the right time to discontinue condom use, primarily when they get into a serious relationship. And I wonder how we avoid going down that road again with PrEP when we move into an era of multiple prevention approaches. And Hyman's data showing, you know, the median amount of time that Black MSM in San Francisco were on PrEP was 4 months. So most people are going to discontinue PrEP. And what are we doing to prepare people?
So I do think that's a critical issue because I think both staying on PrEP when it's appropriate to stay on PrEP, not because it's just been such a hassle to get PrEP or because your provider won't give it to you because they tell you that you're just going to stop using condoms and that's a bad thing and so I'm not going to give it to you and those sorts of things is really important, both staying on PrEP appropriately and also knowing when you can stop. I think one of the reasons that Hyman's been working so hard on SexPro is because it is that kind of a tool that can tell you when to start and when to stop, and that we need to be having those discussions, including about condoms within, you know, certain. There are times when it's appropriate not to use condoms. There are times when it's appropriate to use condoms, and similarly, to take PrEP or not to take PrEP. We do talk about seasons of risk, but then we don't give people the guidance about when is the off season.
Mm-hmm. Hey, first of all, congratulations, City of Chicago. I similarly I consider that a very advanced question, but an appropriate one at this stage of our development. I think it's the mirror image of our challenge in getting individuals, communities, and their treating clinicians to appropriately engage in overt and sustained discussions of sexual and other risk to first identify individuals who are indicated for PrEP and to reevaluate that over time, evaluate their readiness, their capacity to maintain, and evaluate whether it's actually needful at another point. So it's a good problem to have, to be thinking about structured, planned, thoughtful discontinuation. I mostly hear discontinuation as a problem statement, and I think it largely is in this realm. And I very much appreciate Dr. Scott's work in helping both clinicians and individuals quantify and fully evaluate the range of risk at a given moment and over time.
I'm reminded by your question of a presentation I saw at the IAPAC conference earlier this year by one of our colleagues at MGH, who gave a presentation modifying an examination of PrEP adherence by considering prevention effective adherence and looking at adherence using momentary time sampling in the context of risk. I know the navigating risk, particularly as MSM dealing with positive and negative partners, and whether you're positive or negative yourself, viral load considerations, PrEP considerations. The risk navigation now is so complex. You'd almost need a PhD to find your way through it successfully. But I think it needs to get even more complex, particularly when we're talking about 4 days a week adherence providing sufficient protection. I can't help but think, but I don't know of any evidence, scientific evidence yet, to suggest that the individual level barriers to initiating PrEP are probably very similar to the barriers to sustained PrEP use. And that for the immediate future anyway, the priority probably needs to be to identify those. I think as people's risk profile changes and the risk management strategies that they use evolve, it will be an adaptive decision to come off PrEP. And I think we need to be thinking about the PrEP treatment cascade in those regards down the line, so that we don't view everybody who discontinues PrEP as a failure of the cascade. And maybe more sophisticated thinking about that cascade will help that.
Ken Friedberg, question for either Susan or Kevin, with your DPH hats on, and that is we're so much better at doing things like adding pills to our ADAP programs and the like. And I think if we think about the cure session that we're going to have right after lunch, if we had a cure in hand right now, it wouldn't solve any of our cascade or stigma or other problems. And so the question is, how do we take these socio-behavioral interventions, and what level of evidence do we need to start to put those into our portfolios in a meaningful way? Because I think this schism with biomedical and socio-behavioral still is so far apart that how do you do that at the DPH?
Happy to start. When I was wrestling with that question during the presentation, and the note I wrote to myself is, this has to be payer reform. Even in an environment where we allegedly at the national level have medical and behavioral parity in the payment system, we know that's really not yet playing out. I have some excitement about the advent of the accountable care organization structure, because to the degree to which we have a literature base that supports the delivery of behavioral and social interventions to support or as measured by clinical outcomes around HIV care, I think we can make the case for the reimbursement structures for those. We have a history in Massachusetts, you may be familiar with, Ken, of evaluating to what degree the limited resources for HIV and broader public health services can be appropriately deployed to funding what are often extended interventions that require a fairly significant level of technical skill for the deliverer. And it is very the comment that was made earlier, I believe, Carl, you made around the challenges of reach in terms of how many people can we, with that level of resource, deliver these relatively costly and technically challenging interventions. Building them in as a solid predictor of the very clinical outcomes, which in the long run are what we are evaluating our clinical systems by in accountable care structures, I think is where we have to put our policy juice.
And from our standpoint, I would say that our Getting to Zero efforts in San Francisco, we have 3 big initiatives. One is PrEP, one is rapid linkage to care, and one is a retention care. But we also have a stigma group that's trying to work across all 3. And for instance, within the PrEP group, we've got a group focused on providers, a group focused on potential users, a group on measurement. But integrated into all of that is, okay, what's it going to actually take for people to be able to use these tools effectively? And so we're trying to create creative programs for delivery, because if you just you can't just stand on the street corner and give out pills, although that would be a good additional intervention that would take away some of the barriers, but it wouldn't take away all of the barriers.
May I? So Chris Gordon from NIMH, just 3 quick comments and then a question for Connell. Comment is that I respectfully disagree. CFARs are some of the strongest implementation science, I think, that is around the country. So I actually don't think the schism is as wide as you posit, that actually there are many people working on these issues well together in an integrated way. And we are now embedded within NIAID, and so I think that we're actually working fairly well together. For me, it's a question of resources. So that's just one quick comment. The second is when we talk about 90-90-90, and I think you touched on this, that's very hard to achieve. It's a laudable target, but there's the folks who need more. So there's, I guess, 2 comments. And the question is for Connell, which is, given your read of the field, I mean, if you had your druthers, what's the most important, so where would you put your energies and time and sort of focus given the challenges right now?
Wow, how cool it is that somebody from the NIH is asking me that question.
He asked me to ask him.
I think it has to be, and I think it's been said here at this meeting already, I think it has to be an implementation science. If we're looking to moderated effects, to sell the efficacy or the effectiveness of PrEP, where we have to look at adherence for men, or we have to look at adherence and age for women, I think we're already at implementation science, whether we like to think so or not. And obviously the rollout of PrEP will succeed or fail based on how well we can get the citizenry to adhere. And I think that's the same across the board with the work we're doing, trying to offset the effects of depression on engagement in care, or people's staggering trauma history. So I think implementation science.
So very quick question for Susan. We have 3 randomized trials that I can think of, HPTN 065, 068, and CTN 049, either using conditional cash transfer or contingency management, i.e. paying people to do something. The 3 of them are negative. Is that a dead intervention now?
I may not be the best person to answer that, because I probably do think that it's not nearly as effective as we think it needs to be. I don't think it necessarily means that it's dead. I think that there probably are creative ways of using it more effectively, but I guess my focus right now is on other strategies to try to help people to address what their needs are. And you know, there are data from the literature about paying people sometimes devalues what it is that you're asking them to do, because then it doesn't have that inherent value. But I'm not a contingency management focused person, so I'm sure that there are valuable and valid ways of using it. I haven't found that yet, but I assume that there are some out there.
If I could just chime in, I think we know that there are a whole range of interventions to change people's motivation, which may well end up being a more scalable or affordable option than trying to change their motivation extrinsically.
And I guess I want to add to that, there are multiple currencies in this realm, and the freedom to have the kind of sex they really want to have is one of those.
Yes.
I just want to emphasize the point about implementation science, and as that is so essential and critical, it's so important that we get primary care providers to be a part of that picture, so that, because they're the ones on the front lines that are often first up seeing these patients.
I would agree, and I guess I just want to say that I think we've got to think about providers in that full range, because I find that working with mid-level practitioners who could be providing a lot of care, who have been scared away from giving PrEP because they've been told that HIV treatment is such a complex thing, and what I tell them is, this is so much easier than you're treating diabetes and hypertension and congestive heart failure, and PrEP is so easy. And I think depending on what the interventions are, we need to look at the full range of primary care providers.
And this might be something that CFAR might want to really emphasize, I think, and take seriously.
I think when you were asking previously about the training issues, I do think that training mid-levels is really a critical need that we have.
And I just want to add that in Massachusetts, we're also trying to supplement the primary care providers' work because it's in such high demand and short supply that we are also trying to repurpose the existing funded HIV care linkage and screening system to provide some of the supplementary services, some of the recruitment, entry, initial screening, ongoing screening, as well as our state health department field epidemiologists to play supplementary roles so it's not all on the backs of the primary care provider.
Great.
And for PrEP, I think that we could be using psychiatrists, OBGYN, adolescent medicine. I think there are lots of groups that we haven't yet been reaching that could be providing care that see the patient, the very patients we want to get PrEP to.
Well, thank you. I'd like to thank the audience. I'd like to thank our three very excellent speakers, and most importantly, I'd like to thank our panelists. And thanks for staying on when lunch is already late. So get energized for a great afternoon.